So there's some good news in this field. As we learn more and more about cancer, physicians have gotten a little smarter over the years on how to pay attention to certain types. And so we do watch certain markers, tumor markers. These tumor markers are indicators. They're a signal to tell maybe the physician how the disease is progressing, or is our cancer number starting to drop? Are they responding positively to the treatment? Or under diagnosis, it might be that we're uncertain if the patient has prostate cancer, for example, and we need to track the history of that patient to see if the levels of those markers that are coming back are just a function of that individual and not necessarily that there could be prostate cancer. Okay, so let me explain. These tumor markers are typically found on the plasma membrane of the cell, or they're circulating in the blood, or maybe in the spinal fluid, the cerebrospinal fluid, or they could be found in the urine. Now, there's two examples, right? We'll treat both sexes equally. We'll give a male example and a female example, okay? Because cancer is not sexist. It attacks and affects both males and females. Okay, so in the male example, the number one type of cancer that affects males, statistically speaking, we'll look at some of these numbers later, is prostate cancer. Now, prostate cancer is sexist because women can't get it, right? They don't have prostate. But prostate cancer is mutated cells in the prostate of the male, and so the prostate enlarges, the mass of the prostate increases, and the amount of prostate-specific antigen that is found in the bloodstream goes up. And so on a blood draw, we can start monitoring male patients, say in their 50s or 60s or 70s, especially if there's a history of prostate cancer in the family. You might start getting blood drawn earlier and getting PSA levels, prostate-specific antigen, because it's normal for men to have some PSA level in their blood. And we also know that the prostate enlarges slightly as men get older. That's normal, okay? Normal for age. So the question is, are the PSA levels tracking on an increase? And are they increasing because the patient's getting older? Or are they increasing because the patient actually has a lesion in the prostate? And so that's one of the reasons it's important to be documenting what are normal PSA levels for above middle-aged men as they get older and they start seeing their primary care doctor, because prostate cancer, if you're a male, is a very real reality. You got to be cautious about that. Okay, now on the flip side, HER2. This stands for human epidermal growth factor receptor 2. Epidermal growth factor receptor, or HER2, is found in many different tissues in the body, but in breast tissue, it's fairly prevalent in females. So HER2 receptors respond to growth factors and allow the breast tissue to respond to growth signals, as well as hormonal signals during the normal menstrual cycle. HER2 levels of expression go up in female patients when they have breast cancer. Okay? So the way this works, unfortunately, isn't a blood draw. This is actually a biopsy of the breast tissue. So if there's a lump that's identified, maybe on physical exam, there might be imaging that's taken, a mammogram to determine what the size and the shape of that lump is, if it's of concern. If it is, then they would move to the next level of doing a biopsy of the breast tissue. That would go to pathology, and they would stain for HER2 levels. And they would compare those HER2 levels in that patient to normal, age-matched, ethnic-matched HER2 levels. Or they might take a quote-unquote normal sample of non-lump tissue in that same patient and compare HER2 levels from one sample to the other, determine if HER2 levels are significantly upregulated, indicative of breast cancer. Okay? So these are markers that we use in order to help diagnose or watch the level of treatment over time. If you have a patient with breast cancer and you're using chemotherapy, you might look at HER2 levels over time to see if they decrease. Make sense? Same with PSA levels. So these are just two examples. There's many different types of tumor markers. There's those that are specific for glioblastomas. There's those that are specific for pancreatic cancer, for colon cancer, those that are specific for uterine. I mean, the list goes on. Okay. Question?
Can males get breast cancer?
Males can get breast cancer. It's not as common. It's very uncommon in men, but it does happen. It can happen for sure. Men have breast tissue. It's just developmentally, it doesn't have the same signals and cues to do what it does in females. And so if that tissue is sensitive to mutation and there's more activity in that individual, then maybe in some, there could be cancer that forms in breast tissue. Question?
Can breast implants increase your chances of getting breast cancer?
I have seen no data to suggest that there is any correlation between breast implant or augmentation and the incidence of breast cancer. In fact, many of the breast implant cases that happen are usually post-breast cancer in females. Does that make sense? So after they remove the breast completely, patients might elect to have cosmetic surgery in order to emotionally support the recovery or just to have a more typical quality of life. And if there was any data to suggest that you increase your risk of developing breast cancer with an implant, you wouldn't put an implant in a patient that had breast cancer. Okay. It's a good question, though.
Yeah.
So there was a lot of publicity. My lab actually published a paper on this. Back in the early days of breast implants, they are a biomaterial. The early ones were Dow Corning, and they were a silicone implant, and they would become compromised. The actual bag would become compromised when you get silicone leaking, and that did cause some problems in patients. But it was pretty blown up by the media as to the significance and the size and the volume. Now, the patients that had major problems would agree that it was problematic, but it wasn't every single implant. It was probably, they had to recall those devices, and they redesigned them. So the ones that are on the market now are extremely safe. You don't see really any problems associated with the device itself. A lot of the problems are associated with anesthesia or with the surgery itself, not necessarily with the implant.
So with the inflammatory lecture, you showed us how someone that had a hip replacement, the actual blood cells went to attack the hip.
Mm-hmm.
Wouldn't that happen with an implant?
Well, any implant that you put in the body is going to stimulate a response. Doesn't matter what it is. So you're going to get a response. What's that?
Wouldn't that cause it to leak?
Oh, not necessarily. No, it might cause a local inflammatory response. It might form a fibrous capsule over years, but then the body kind of leaves it alone once it walls it off. But I mean, patients, there's all sorts of different types of implants other than hips. Dental implants are extremely common. Fewer and fewer patients wear bridges or dentures, they get implants. That's not anything different than a orthopedic implant in a hip or a knee, or if anybody had surgery and there's any kind of metal left over, all of that's stimulating some bioresponse to it, right? If you have a screw or a plate or any kind of appliance from a fractured bone or anything like that. No, there was one more question? Yes?
Is there a correlation between breast size and breast cancer because you have more cellular replication?
I haven't seen any data to suggest that breast size increases your risk of developing cancer. I haven't looked into it very carefully, but I think it's more about what's happening at the level of the DNA, not necessarily what happens like during puberty when breast size is pretty much established. During the time of puberty when the woman is developing, post-puberty, you don't see a lot of breast cancer associated with adolescence. I mean, it is more prevalent post-adolescence than it is in adolescence. So the normal breast process wouldn't lead me to believe that there's any extra risk associated with breast size. Okay, let's get into some of the genetics. So, keeping in line with breast cancer, so this is a cut section of a ductal carcinoma of the breast. Right in the center, that white center piece would be very, very solid. It would be like stone. Okay, so that would be the lump that individual would feel on self-examination, or the physician would feel on physical examination. And because they're hard and stony, they show up on X-ray on a mammogram. They actually show up as a white spot, as a lesion, as a dense object. Okay? Now, let's talk a little bit about these mutations that take place. So these mutations that take place in cancer can be numerous. And typically, we've got more than one mutation that's going to happen in a cancerous mass for it to actually be problematic. If it's a single mutation, it would be considered a concern, but it may not be sustaining for the cancer. In order for the cancer to be successful, if I can use that terminology, right? Because the cancer success, from the cancer's perspective, is to invade and take over. And in order to do that, you would want to have mutations in a couple of different pathways in order to encourage the opportunity for success, meaning metastasize. Now, the other way of looking at it is, if we have fewer mutations in that cancer, it would be less risky. It'd be less likely to cause problems, okay? So if you look at this wheel diagram, we've got these images that represent, this is from your textbook, but I like it a lot, and that's why I put it up here, this is a symbol that looks at replication, okay? So you might see a mutation that could affect replication. This is a symbol that's talking about anti-growth signals, meaning signals that tell the cancer cell or the cell itself to stop growing. And so cancer cells could have a mutation where they're insensitive to the arrest to growth signals. Here's a symbol that talks about invasiveness and metastasis. And so they could have a mutation that makes them more invasive. They could have a mutation that means that they replicate without stopping, right? They're immortal. They could have a mutation that gives them extra blood supply, meaning that there's angiogenesis that's very prolific within that tumor mass, okay? Or they could evade death, right? They could evade apoptosis or cellular death. And that is one of the first mechanisms that your body uses when it detects that there's a cell, your cell, that's misbehaving. If it's detected as being misbehaving, then it might be signaled for apoptosis. But cancer cells could mutate where they avoid the apoptotic signal, and they go undetected. Okay? So let's look at each of these in the subsequent slides. Now, before we move on, I need to talk a little bit about oncogenes and tumor suppressor genes. Okay, and then we'll get back to some of these mutations. But this is in the line of mutations. Now, oncogene is a gene that can be mutated or overexpressed at a high level, and then that turns that cell from a normal cell into a tumor cell. It has the potential to cause cancer. They're ones that are very often mutated. So there's a high prevalence of certain genes becoming mutated those genes that are at a high risk of being mutated are on a short list of oncogenes. Many of the cancer drugs that we develop are targeting these oncogenes, and that's why they're well understood. Now, how does a gene become an oncogene? Well, it mutates. And there's really three ways that mutation can actually happen. Number one is you can have a point mutation or a single base mutation, where you've got the replacement of a single base nucleotide with another nucleotide in the genetic material, right? So instead of an adenosine, you put in a cytosine, for example. Okay, instead of an A, it's a C. And that little point mutation causes the insertion of a single base pair that's not supposed to be there. And now the code is going to code for something completely different than what it should have. A second way that this can happen, so you can see how a point mutation could happen very easily, right, in replication. Second way this could happen would be amplification. This is also known as gene duplication or chromosomal duplication. It's a cellular process where you get multiple copies of the gene being produced instead of a single copy. And now you get an amplification of that particular phenotype. So instead of making one copy, you made 2, or 3, or 4. Gene duplication, chromosomal duplication, or gene amplification. A lot of times it occurs because there's a genetic defect or a flaw in a group of cells. And we don't really understand why this happens, but there may be some evolutionary implications that have led up to maybe a previous benefit to having amplification of certain gene sets. So that's why this mechanism is still present and shows up at random intervals. Okay, now the last one is chromosomal translocation. So here, we've got a rearrangement that takes place between non-homologous chromosomes, where the gene fusion happens. You get a translocation joining two otherwise separated genes, and now you've expressed something that wasn't supposed to be expressed. So you take a point of the genetic code, you translocate it to another location, and now it's being expressed in a new area, and you really result in something completely new. Okay? So all three of these things can take place. Now, we in our body have what we call tumor suppressor genes, and there's many of them. I'm only going to characterize 2. You will only be tested on 2. But I want you to understand that there are more than 2. Is that okay? Is that fair? You have to learn 2, be tested on 2, but recognize that there's many, many more than just 2 tumor suppressor genes. So these are anti-oncogenes. That's another name for them. They protect the cell from a step in the process to cancer. However, if they become mutated, you're at high risk of developing some sort of cancer. If a tumor suppressor gene, right, becomes mutated, that's your defense mechanism against cancer. So let's look at one of the most famous ones, P53. It's not the first one that was described, but it's definitely one of the most famous. It's called tumor protein 53. TP53 or P53 for short. Okay? This is the central monitor of stress in the cell. It's been described in the literature as the guardian of the genome. Kind of a cool name, like superhero. So guardian of the genome. It has a very high turnover, and it's present in cells in low levels in a non-phosphorylated state. That's inactive. When there's DNA damage, it's phosphorylated in multiple sites, it's activated, and it does its thing. Okay, we're going to talk about what it does here in a second. Now, P53 highly responds to hypoxic damage. So if you have low oxygen levels in the cell, or the cell's under stress due to hypoxia, P53 is going to be turned on. Now it'll be turned on for any kind of stress but it's especially sensitive to hypoxia. So if you look at this slide, you've got a normal cell here and a normal cell here. Here we've got DNA being damaged. P53 binds to, it activates by being phosphorylated, binds to the DNA, okay? And then it arrests replication. It arrests replication through two potential mechanisms. Number one is through P21, and number two is through GAD45. Both of these arrests or stops pauses the cell replication in GAP1, G1 phase, okay? It allows for correction to take place of either the point mutation or the translocation that might be present. And if it's successful, then you proceed with replication, you get normal cells. Now, P53 is active in all of us right now. And the reason I know that is because at some point today, you walked here from outside, from your car, rode your bike, okay? And you received UV radiation, which is damaging to cells, on your way into this classroom. At some level, it's active right now because you're receiving radiation from something. A little bit's coming from that projector, some of it's coming from the screen that you're drawing on, others coming from your back pocket, from your phone that's in your back pocket, right? So there is radiation that you're being exposed to throughout the entire day, and as radiation goes up, P53 levels are activated, and it goes up, and it pauses your cells before they replicate to make sure that there isn't any mistake, okay? If it cannot fix it, it triggers the apoptosis gene, which is known as BAX, B-A-X. And then it triggers that cell to go through apoptosis so that you can recycle the parts but not propagate the mutation. Make sense? This is normal activity, normal function of P53. Okay? You with me? If you have P53 that's normally supposed to do that, that fails because it's not activated. There's a mutation. It doesn't become phosphorylated. It's not upregulated. Then it won't have its activity of pausing the cell cycle. The mutation, the point mutation, will be replicated. Okay? The translocation will be replicated, or the gene amplification will be replicated, and that will expand and allow for the mutation to propagate. Now, the mutation could be something pretty minimal. Like it could be, it grows the tumor. The cells, the mutation that never got caught was an increase in cellular divisions. And now all of a sudden, you get a little bit of a lesion underneath the skin. Okay? Like a lipoma. Well, isn't that a problem? Well, if that's the only mutation that happens, it'll probably only get to a certain critical size, and then it'll kind of stop on its own. Why? Well, because it's not going to have enough nutrition to grow beyond that. Right? If it doesn't have a vascular supply that it brings in, it's not going to be able to grow. If it doesn't have a signal to metastasize, it's not going to go anywhere. It's going to stay right there. So if you have that one mutation of growth, it may only form like a little bit of a subcutaneous lump, right? That you can grab and move around. It's not a big deal. We call it a lipoma. Not a huge deal. You can remove it if you like. It's more cosmetic. We're going to keep an eye on it. Why are we keeping an eye on it? Well, if it starts to grow more, that means another mutation has happened. You guys with me? So in that case, P53 might have slipped, but that might have been the only slip that it had. Okay? You guys tracking with me? Okay, so do you understand what tumor suppressor genes do? They actually try to prevent the mutation from being propagated. Okay? Now, there's another example of a tumor suppressor gene that I want to characterize. P53 is kind of the main one, but the other one is known as retinoblastoma. And this one was the first cancer suppressor gene or tumor suppressor gene to be identified. It also has a similar activity in that it enforces the gap phase, G1, to pause replication. But its another tumor suppressor gene. Do you understand that this is a different one? Has a very similar activity as P53, but it's different. But there's overlap. So that should tell you if the body has more than one tumor suppressor gene that kind of has similar activity, that must be an important activity, right? That's called redundancy. So retinoblastoma, RB, also operates in the way of being phosphorylated or unphosphorylated, okay? Hyper or hypophosphorylated. Well, what I want to show you here is how it normally operates is shown on this slide, okay? So you've got a hypophosphorylated state, right, where retinoblastoma is kind of this coat hanger thing right here that's sitting on top of this E2F. In its hyperphosphorylated state, where you add 4 more phosphate groups on the left, you can see that the coat hanger unlatches from E2F and comes off E2F. But when it's underphosphorylated, okay, it actually sits down on the E2F site and helps to block transcription at the S phase, right? So S phase genes, transcription block, you prevent transcription of the gene happening, and you arrest this in GAP1. And this is normal activity of retinoblastoma. Now, if retinoblastoma sits down, pauses it, it blocks transcription, you check the integrity of the DNA and it's good, then you hyperphosphorylate it, you lift it off the E2F, E2F comes off of the E2F site, and then transcription actually continues, and you replicate. So, normal activity of retinoblastoma. You guys with me? In its underphosphorylated or hypophosphorylated form, it blocks transcription, pauses transcription, allows for you to check the integrity of the DNA. If everything's cool, you phosphorylate it with 4 more phosphates on the right side. It moves that coat hanger off of E2F. E2F comes off the transcription block, and you allow replication to take place. This slide, you can write on here, this is normal activity of retinoblastoma. Now, if there's a mutation with retinoblastoma, let's pretend the mutation keeps retinoblastoma in its hyperphosphorylated state. What's the risk? You tell me. The mutation to retinoblastoma keeps RB in a hyperphosphorylated state all the time. What's the risk? Somebody tell me.
Transcription would go unregulated.
Transcription would happen unregulated. Perfect. If it happens unregulated and there's a miscoding of a base pair, if there's a amplification that takes place, if there's a translocation, you don't catch it. Does that make sense? Okay. I just described 2 mechanistic activities of 2 different tumor suppressor genes. There are dozens, right? You can write these down if you like. They're not going to be on the exam, but just for the sake of completeness. You got APC, CD95, ST5, YPEL3, ST7, ST14, and the list just keeps going. Okay? So there are numerous identified tumor suppressor genes in our body, constantly trying to make sure that the mutations don't get propagated. Okay? Very, very important. First here and then back here.
The arrow is pointing down, so is it coming off or is it coming down? I'm kind of confused.
Which arrow? There's a few arrows here.
For the hyper.
The hyperphosphorylated to the hypo to the hyper.
Yeah, the hyper.
The middle.
So these 2 arrows are both pointing downwards. So is
Yeah,
it
it's-
coming down or is it going up?
So, in this particular situation, E2F will sit down on the E2F site.
Okay.
If retinoblastoma is covering it, it blocks transcription.
Okay.
Where E2F is sitting on the E2F site with no retinoblastoma, transcription happens. Does that make sense? Okay. Yep. I didn't know there's an arrow here, there's an arrow here, right? Arrows, there's like 17 arrows there. Pointers. Okay. So we talked about like a growth promoting mutation. There are many different mutations. Remember the wheel diagram? Let's go back to that. That's what's up in here in the upper left. If the only mutation that cell does is to grow, you'll probably get a lesion that grows to a certain size. My dog has this. Like on his belly, he's got like 3 of them. These little lipomas, right? He's 10. And you can only tell they're there when he like rolls over and we rub, and you can feel this little bump, right? And it's completely encapsulated. It's not adhered to a basement membrane. So the vet, tells me just make sure it's not getting bigger, and make sure that it's palpable and you can move it around easily, and it doesn't cause some discomfort. Right? Those are the parameters. Why? Well, the moment that it's no longer movable, it's grabbing onto something and it's trying to penetrate, and it's becoming metastatic. You with me? And if it's attached and I start moving it and pulling on it, it's probably going to be a little painful, and you might wince or turn away or, snap or something. So it's just a lipoma. And it's very common in retrievers and a lot of different breeds to get these little fatty masses underneath the skin. Even in the human breed, okay, it's very common. But once other mutations start happening is when we start getting concerned. And so one of these mutations, or a few of these mutations that we'll see, are on this slide. So you can see on this slide, we've got collagenases, matrix metalloproteases, and other proteases. So if the cell decides that it wants to penetrate through a basement membrane and start metastasizing and going into another site, it has to chew away tissue. It has to chew away matrix, so it needs to make enzymes. So if it mutates to make more enzymes, then it's going to break away the tissue around it so that it can actually migrate. And that's part of it becoming metastatic. So that would be a different type of mutation. With me? So that would be invasion, a mutation in invasion. This allows it to penetrate the body cavities or the blood vasculature into the lymphatic system, and then it can migrate all throughout the body. So if a lesion starts in the liver or in the lung and it gets into the circulation, a lot of times it can actually metastasize up into the brain. And that's actually what happened with my mom. Right? And bone, it can start in the bone, it can metastasize in other places. If you have it in the abdominal cavity, like in the pancreas, okay, or in the spleen, it can metastasize and move out into the abdominal wall. If it's in the colon, it can metastasize from the colon, get into the abdominal wall as well. How does it migrate? It makes enzymes to digest away the tissue surrounding it. That is a point mutation that's not supposed to be there. You guys with me? Okay. Then, when it gets into, let's say this example is the vasculature, it gets into the vasculature, it goes to a secondary site, and now it extravasates because it makes enzymes to chew away this. And here you're already starting to see an angiogenic mutation that stimulates it to retrieve or create its own angiogenic blood supply so that it can promote its growth beyond just a controlled lesion. Okay? So one question that I have for you on homework is the following. I want to see if you can, this would be great for SI, okay? See if you can describe the development of a malignant neoplasm. One that's a new growth that's going to metastasize. You should include the terms of normal, dysplastic, in situ, and invasive. See if you can do that, how well you can do that. Okay? So try that in SI this week. This would be a great way to know if you actually are understanding the material well.
My question was about
Oh, I forgot to ask you a question. I
it's
apologize.
okay.
Yeah.
It's about the retinoblastoma.
Yeah.
Is that just normally at low levels and only gets triggered at a certain time? Like P53?
Yeah, it's similar to P53. It's in low levels, and then when there's activity, then it raises its activity. When there's concerning activity, it raises activity. That's correct. Yes.
Don't you need white blood cells in order to actually create angiogenesis?
No.
And what was C2?
What's that?
C2.
Oh, in situ. So this term goes back, I might have missed that on the slide. So when we talked about carcinomas, and we talked about sarcomas, and we talked about adenosarcoma, lymphoma. So a carcinoma in situ, like that skin lesion, the word in situ means in location. So it's usually referring to a epithelial lesion that's in a specific tissue, and then you name it by that tissue bed. So just the word carcinoma in situ means carcinoma in location. That's how that translates. Okay? I apologize for skipping over that. Okay. This is a picture of a liver. We looked at a piece of breast tissue. This is a liver. And all of these white lesions are metastatic cancer. This thing is, like we say, studded with metastatic cancer. Now, we start in a primary tumor. We get a metastasis or a met that goes to a secondary location. It can travel through the bloodstream, through the lymphatic, through the body cavities, like we saw in the previous slide. But once it gets to its end location, if it's going to survive, it needs to have a mutation that allows for additional blood flow to move in, and it needs to be angiogenic. So, how is it that these cancer cells become angiogenic? Well, the tumor mass itself starts to release angiogenic growth factors. They start manufacturing things like vascular endothelial growth factor. And vascular endothelial growth factor, to your question a little bit earlier, is it stimulates the blood vessel tube to become leaky. It moves those endothelial cells away from each other, and then they start to branch out. As they branch out, they start to divide, building a new blood vessel tube that creates a network, a new vascular supply of that particular tissue. And this is how angiogenesis is promoted and how these tumors actually grow. So there was a famous cancer researcher by the name of Judah Folkman, and he was most well known, he's passed away, but he was most well known for his anti-angiogenesis research. So his idea was a way to kill cancer was to actually starve it and to block blood vessel formation, where you keep that tumor lesion to a certain critical size and it never grows beyond that because it never develops its own vascular supply. It's not uncommon for these large tumors as they grow to have a necrotic core because they're growing so fast. Even if they bring in new vasculature, the middle or the central core is actually necrotic. Okay? The diffusion distance of oxygen in tissues is about 250 microns. That's it. That's as far as O2 will move in the tissue supply from diffusion, from high to low concentration. So outside of 250 microns of tissue, you usually have to have a new blood vessel that's providing perfusion into that tissue bed. So I'm going to pose this question. For years, some cancer prevention researchers, like Folkman, looked at shark cartilage to investigate different types of treatment strategies for cancer patients. Why do you think they chose shark cartilage for their research?
Would it be because of its flexibility?
It's a good guess. Flexibility, it's not exactly why.
The body wouldn't recognize it to create angiogenesis.
It's avascular. Cartilage is fairly avascular. Shark cartilage doesn't have much blood vessels in it. And so if you can understand how shark cartilage develops in the body and then loses its vascular supply, mechanistically, you might have some ways that you can piggyback on that knowledge to turn off blood vessels in a tumor and then cause the tumor to shrink. So a lot of the anti-angiogenesis research, not only would it prevent tumors from growing, it would actually cause tumor regression. They'd actually shrink in size by giving anti-angiogenic therapy. It's pretty cool. Okay. Clonal proliferation. There's 2 more slides in this section, and then we'll pause. So I want to show you how we go from over here to a normal cell all the way to this evolution of a extremely malignant cancer. And it goes to that wheel diagram, and the point that I want you to walk away from is this. Cancer, in its most dangerous form, its most malignant and most aggressive, has multiple mutations, not just one. So usually some oncogene or some tumor suppressor gene hasn't been doing its job for a while, and it gets really bad, okay? So you've got a normal cell here. You've got some mutation. How does it happen? Well, there's a mutagen. That's like a carcinogen. It could be radiation. It could be environmental. It could be something toxic that causes a mutation at the level of the DNA. And now you get this mutation of this tumor cell. Well, that tumor cell continues to mutate, and it goes to these different variations as it mutates. And this variation dies off because it wasn't favorable. This variation actually continued. This variation also died off because it wasn't favorable. From here, you get another mutation, and then another, and then you can see on the outcome, the blue mutation was actually a non-antigenic mutation. The orange, or peach, was it needs fewer growth factors to respond to growth signals. The red was a metastatic mutation, and the teal was an invasive mutation. Now you've got this tumor mass that had multiple mutations. You can put another one, you can draw a line and say, this one was creating more enzymes. You can draw another line saying, this one was for more VEGF production, making more angiogenesis. You see what I mean? You get this tumor mass that has 4 or 5 different mutations that are favorable to the cancer's survival, then it becomes really problematic. Those are our most dangerous types of cancers. Okay, to summarize in this section, I want to encourage you to take a look at this slide. This is our last slide for today. We've got a normal cell. You can walk through this and you can explain to your study partner, maybe an SI, what's going on in each one of these boxes. What are some of the details around it that make up this box? That would be a great study tool, okay? So you can see a normal cell, there's DNA damage. You get repair that takes place if P53 and retinoblastoma are doing their thing. Causes replication or any other tumor suppressor gene. And this happens all day long right here. We go from a normal cell to some damage, we repair it, we go back and forth. At some point along the line, we get a failure of the DNA to repair. What causes the damage? Look, chemicals, radiation, even viruses. We'll talk a little bit more about that in the beginning of next week when we pick this up. But if you fail the DNA repair, then you get mutations in the level of the genome and some of the somatic cells. You get these alterations that take place. You unregulate cell proliferation. You lower programmed cell death. You clonally expand the mutation. That's what this is right here. This slide is really clonally expanding mutations. Now you get these point mutations like angiogenesis or an escape from immunity. You get all these additional mutations that we saw over on this slide that make up this really dangerous cancerous mass. The tumor progresses and it becomes extremely malignant and breaks off and goes into other tissues. Okay? That's where we'll stop today. Have a great week. I'll see you guys.